Today's topic is Neonatal Hyperbilirubinemia and Hemorrhagic Disease of Newborn. Two topics are there. First, Neonatal Jaundice or Neonatal Hyperbilirubinemia. So, there are two types of Neonatal Hyperbilirubinemia, physiological and pathological. Physiologic jaundice is very common in first week of life or in first 2 weeks of life. Over 2/3 newborns develop clinical jaundice and they don't require any intervention. Few babies develop severe form of neonatal jaundice that require phototherapy or exchange transfusion, and that can result in irreversible neuro disability or death if not managed timely. So, all newborn babies must be screened at least twice a day to detect the onset and severity of jaundice, and screening is important from day 1 of life because pathological jaundice appears on day 1. Now, the bilirubin metabolism. Mostly these you have studied earlier. Now, there are several heme containing proteins. Mainly is their hemoglobin. Now, breakdown of hemoglobin and other heme containing proteins causes production of bilirubin. Actually, the heme is converted by heme oxygenase to biliverdin and carbon monoxide. Then biliverdin is converted to bilirubin by biliverdin reductase. Okay, so this bilirubin is unconjugated and this bilirubin is bound to albumin. This is not free. If this bilirubin is not bound to albumin, then what will happen? This free bilirubin will cross blood-brain barrier and causes Kernicterus or acute bilirubin encephalopathy. Now, what are the factors like hypoxia, metabolic acidosis? These factors are aggravating factor for crossing the blood-brain barrier and causing Kernicterus. Now, this unconjugated bilirubin bound to albumin transported to liver, hepatocytes, and conjugation process happens there by the enzyme glucuronosyl transferase. Okay. The full name is uridine diphosphogluconurate glucuronosyl transferase. After conjugation, this conjugated bilirubin goes to GI tract, gastrointestinal tract, and excreted in bile. But in newborns, there is enterohepatic circulation. Beta glucuronidase enzyme converts this conjugated bilirubin to unconjugated bilirubin, and this unconjugated bilirubin again transported back to liver. That's why due to this enterohepatic circulation, the proportion of unconjugated bilirubin is very high in newborns. Now, what are the aggravating factors that leads to more enterohepatic circulation? Preterm breast milk and bowel obstruction. In preterm babies, in breast milk jaundice and in bowel obstruction, there will be more enterohepatic circulation and there will be more unconjugated bilirubin. Decreased conjugation. If there will be decreased conjugation, then unconjugated bilirubin will be more. What are the conditions in preterm babies? In Crigler-Najjar syndrome, and Gilbert syndrome. In Gilbert syndrome, the activity of this enzyme glucuronosyl transferase will be low, and in Crigler-Najjar syndrome, there will be complete or near complete absence of this enzyme. So, when enzyme activity will be low or enzyme will be absent, so there will be no conjugation, and proportion of unconjugated bilirubin will be more. That leads to more indirect or unconjugated hyperbilirubinemia. And what are the factors that aggravates the breakdown of hemoglobin and also heme containing proteins? These are polycythemia, bruising or cephal hematoma, hemolytic anemia, causes of hemolytic anemia, that is ABO incompatibility, G6PD deficiency, spherocytosis, maternal diabetes, IDM, infant of diabetic mother. So, this is the metabolism of bilirubin, and these all factors will cause more physiological or pathological jaundice, more indirect hyperbilirubinemia. Now, what are the differences between physiological and pathological jaundice? How to differentiate? Physiological jaundice appears after 24 hours, that is from day 2 or day 3. Total bilirubin rises by less than 5 milligram per deciliter per day. And pathological jaundice appears before 24 hours of age, that is in day 1. Day 1 baby will develop pathological jaundice, and here increase of bilirubin level will be more than 5 milligram per deciliter per day. In physiological jaundice, serum bilirubin level will be around 12 to 15 milligram per deciliter. In pathological jaundice, serum bilirubin will be more than 15 milligram per deciliter. And in physiological jaundice, maximum level of bilirubin will be by 4th or 5th day in term babies and by 7th day in preterm babies. And in pathological jaundice persisting beyond 14 days of life. Normally physiological jaundice persists in term babies up to 14 days. And in preterm babies, it may persist up to 21 days. Okay. So, clinically not detectable after 14 days in term and 21 days in preterm, and resolves without treatment. Okay. Treatment is not needed. And in pathological jaundice, there will be direct bilirubin. Conjugated hyperbilirubinemia will be there, that is neonatal cholestasis will be more than 2 milligram per deciliter or more than 20% of total serum bilirubin. Presenting feature will be clay or white colored stools, dark urine, okay. And signs of underlying illness. There are several causes of pathological jaundice. Symptoms or clinical features will be according to the underlying condition or illness. Now, causes of physiological jaundice. First is total RBC volume is more in newborns, that is physiological polycythemia. So, total RBC volume will be more, and decreased RBC survival less than 90 days. Normal survival of RBC is 120 days. So, there is increased production and decreased survival. So, there will be breakdown of RBC. Then poor hepatic uptake and conjugation. Hepatic uptake will be poor, so conjugation will be poor because conjugation occurs at hepatocytes, and due to transient deficiency of cytoplasmic ligandin Y protein. This is carrier protein, helps to transport bilirubin and the enzyme UDP glucuronosyl transferase. So, deficiency of this carrier ligand in Y and UDP glucuronosyl transferase, this enzyme will cause physiological jaundice, especially in premature and late preterm babies. Then increased enterohepatic circulation. Enterohepatic circulation will be more, so conjugated bilirubin will again converted to unconjugated bilirubin. There will be indirect hyperbilirubinemia. Now, breastfeeding failure jaundice causes breastfeeding failure jaundice. Okay? Lack of breastfeeding, lack of gut clearance, and increased enterohepatic circulation, because enterohepatic circulation occurs from gut. Beta glucuronidase enzyme is there. Overactivity of intestinal beta glucuronidase enzyme and paucity of bacterial flora in the gut. Now, there are bacteria in the gut which converts this bilirubin into conjugated bilirubin into urobilin. Because of this conversion, conjugated bilirubin is not there, that is converted to urobilin. So, conjugated bilirubin is not available to become or undergo deconjugation. So, there will be less unconjugated bilirubin. Pathological jaundice, causes of pathological jaundice, hemolytic causes. First, Coombs test positive or Coombs test negative. In positive, there is ABO incompatibility, ABO and RH incompatibility. And in Coombs test negative, there are several causes. RBC membrane defect, all are causes of hemolytic anemia. RBC membrane defect, spherocytosis, elliptocytosis. RBC enzyme defect, that is G6PD deficiency. Hemoglobinopathy, that is thalassemia. Then infection, sepsis, hematoma, bruising, and some drugs, vitamin K, oxytocin. So, these are all are causes of hemolytic anemia and cause pathological jaundice. Now, there are some non-hemolytic causes of pathological jaundice. Breast milk jaundice, because beta glucuronidase is available or is present in breast milk, that increases enterohepatic circulation. Then Crigler-Najjar syndrome types 1 and 2, the enzyme will be complete or near complete deficient. Gilbert syndrome, enzyme activity will be low. And IDM, infants of diabetic mothers and hypothyroidism. So, when there is pathological jaundice, we have to evaluate the case and rule out the causes, because there are several causes. So, we have to diagnose the exact causes of pathological jaundice. So, in jaundice, what history to be taken? Like family history of any jaundice, anemia or splenectomy, because there may be chances of hereditary hemolytic anemia. Then if there is any history of liver disease in the family, because of cystic fibrosis, Crigler-Najjar, tyrosinemia, okay, and sibling history. If there is history of prolonged jaundice or pathological jaundice in sibling, breast milk jaundice or blood group incompatibility. So, family history is very important. Then pregnancy history, any illness during pregnancy, any complication, maybe fever with rash, maybe there is chances of torch infection. So, history of illness in antenatal period. Then IDM, again infants of diabetic mothers. So, there is history of diabetes in mother, maybe gestational diabetes, and maternal drugs. So, pregnancy or antenatal history is also important. Then labor history or natal or labor history. What history to be taken? Birth trauma. If there is trauma and bleeding during labor, or there is instrumental delivery, that is vacuum extraction, then infants with HIE, hypoxic ischemic insult, that is if there is history of perinatal asphyxia, baby didn't cry immediately after birth, and delayed cord clamping. So, there will be prolonged jaundice in delayed cord clamping. More blood will be transferred to the baby. Now, infant history. If there is history of poor feeding, vomiting because of sepsis, and in case of pyloric stenosis, baby will present with vomiting, then delayed or infrequent stooling, not passing stool regularly, there may be intestinal obstruction, may be subacute obstruction, and excessive sleepiness, temperature instability, shrill cry, all are features of HIE or encephalopathy. Now, in examination, physical examination, we have to assess the severity of jaundice and in natural daylight, that is very important, okay. And progression of jaundice is cephalocaudal from head to toe. However, visual inspection is not a reliable indicator, but commonly for screening purpose, we do this visual inspection and assessment of clinical jaundice. The clinical jaundice by following this Kramer's rule or Kramer's jaundice. Now, there are 5 zones, Kramer's zones. Number 1, face and neck. If there is mild jaundice, the level will be 5 to 7 milligram per deciliter, and if there is deep jaundice, orange yellow color, the level will be 7 to 9 milligram per deciliter. Then 2, chest and upper abdomen. If jaundice is there in chest and upper abdomen, so bilirubin level will be, in case of mild jaundice, 7 to 9 and deep 9 to 11 milligram per deciliter. Then third region, that is lower abdomen and thigh. If there is jaundice in the region 3, the level of bilirubin will be 9 to 11 in mild jaundice and 11 to 13 in deep jaundice. Then come to region 4. Region 4 is total arms and leg. Here the level of bilirubin will be 11 to 13 and in mild jaundice and 14 to 16 in deep jaundice. There is almost level of 2 milligram per deciliter difference in mild and deep or severe jaundice. Okay. That is the difference in color, lemon yellow, mild jaundice, and deep yellow or orange yellow, that will be deep jaundice. Level of 2 milligram per deciliter bilirubin will be more. And last, if palms and soles are stained, then the level of bilirubin will be 13 to 15 in mild and 17 milligram per deciliter or more in deep jaundice. So, there will be cephalocaudal progression from head to toe. So, we will check the level of bilirubin. The jaundice is there up to thigh or up to leg, then we can assess the approximate bilirubin of serum bilirubin in blood. Now, there is another method, that is transcutaneous bilirubinometer. Transcutaneous bilirubin estimation, the most advantage is it is non-invasive. So, but there are some limitations, that is transcutaneous bilirubinometer is not reliable for TSB more than 15 milligram per deciliter during or after phototherapy or sunlight exposure. Before giving phototherapy, we can screen the baby by measuring bilirubin via transcutaneous bilirubinometer. But once phototherapy has started, this bilirubinometer is not reliable, and it screens the newborn or infants for more than 35 weeks. Again, this is not reliable for babies less than 35 weeks. Total serum bilirubin that we measures by taking the process, okay, and this Van der Berg or Diagnostic method for total and conjugated bilirubin estimation is followed, and measurement of end tidal carbon monoxide breath level, carboxyhemoglobin also reliable. I have stated earlier that bilirubin is converted to biliverdin, heme is converted to biliverdin and carbon monoxide. Same amount of biliverdin and same amount of carbon monoxide is produced. So, by measuring the carbon monoxide level, we can assess the level of bilirubin. What are the additional lab tests to be done? Because there are several causes for pathological jaundice already discussed. Now, first ABO, for ABO incompatibility, mother's blood group RH and antibody screen, and infant's blood type RH and direct antiglobulin test. For ABO and RH incompatibility. Then peripheral smear and retic count for Coombs negative hemolytic disease. If there will be any special cell in peripheral smear, or if retic count will be more, then hemolysis will be more, conjugated bilirubin will be more. Then in polycythemia, for polycythemia what to be checked? Hemoglobin and hematocrit. Then direct or conjugate bilirubin in when TSB, total serum bilirubin, is approaching phototherapy threshold, or if jaundice more than 2 weeks. Direct bilirubin measurement has role in neonatal cholestasis, where jaundice is persisting for more than 2 weeks. T6PD measurement mainly in boy babies if TSB is more than 18 milligram per deciliter, and if prolonged jaundice, so test for liver disease, congenital infections, torch infection, metabolic defects, any inborn error of metabolism, galactosemia, sepsis or hypothyroidism. So, these tests to be done and causes to be ruled out. Now, management. How to manage a case of hyperbilirubinemia, indirect hyperbilirubinemia. What is the aim? To prevent severe hyperbilirubinemia and to prevent acute bilirubin encephalopathy. In term and late preterm, in late preterm or preterm babies, there will be more chances of acute bilirubin encephalopathy or Kernicterus. Now, treatment is based on our specific bilirubin and gestational age. There are some graphs I will show. So, this is the graph phototherapy threshold with no neurotoxic or neurotoxicity risk factor. No hyperbilirubinemia neurotoxicity risk factor. There are several lines according to the gestational age. We will plot the level of total serum bilirubin in the graph and see whether phototherapy is required or not. If the value according to the gestational age comes under the respective line, then phototherapy is not needed, otherwise phototherapy will be given. And this graph is for phototherapy, but when one or more hyperbilirubinemia neurotoxic risk factor is present. I will tell later what are the neurotoxic risk factors. Neurotoxicity risk factors are: first, gestational age less than 38 weeks. Risk increases with degree of prematurity. Baby will be more premature, there will be chances of more acute bilirubin encephalopathy or Kernicterus. Isoimmune hemolytic disease, ABO and RH incompatibility, G6PD deficiency and other hemolytic conditions, other causes of hemolytic anemia. Albumin less than 3 gram per deciliter, sepsis or infection, and significant instability in previous 24 hours. Baby's vitals are not stable. If any of these neurotoxic risk factors are present, then the second graph will follow. Otherwise, the first graph. Now, phototherapy, the main treatment is phototherapy. Phototherapy given to the infants to prevent severe hyperbilirubinemia or acute bilirubin encephalopathy. Now, intensive phototherapy, ideal phototherapy should produce decline of in TSB of 1 to 2 milligram per deciliter within 4 to 6 hours. If there is decline of bilirubin 1 to 2 milligram per deciliter within 4 to 6 hours, then be assured that phototherapy is effective and given in correct way. And phototherapy also provided to infants of bilirubin toxicity or acute bilirubin encephalopathy. When even we are preparing for exchange transfusion, then also phototherapy will be continued. Now, the device by which phototherapy is given, light emission in the blue-green spectrum, wavelength is 460 to 490 nanometer, and 460 nanometer wavelength is most effective because here bilirubin most strongly absorbs light. Now, what are the mechanism of this phototherapy? First or most important, the mechanism is structural isomerization. In structural isomerization, phototherapy converts the bilirubin to lumirubin. Lumirubin, this is water soluble. This is excreted in bile and urine. This is the main mechanism or main way of reducing indirect bilirubin. Other two mechanisms are photoisomerization, changing of isomer from 4Z15Z to 4Z15E. Again, this isomer is less toxic and can be excreted to bile, but it is reversible. So, this mechanism is not so much effective. And last one is photooxidation. This converts bilirubin into small polar products, that is again polar, so water soluble, and it is excreted in urine. So, three mechanisms are there: structural isomerization, photoisomerization and photooxidation. Now, how to give phototherapy? Ensure exposure of maximal body surface area. Only eyes will be covered and genitalia will be covered because there are chances of retinal damage and gonadal damage. So, eyes and genitalia will be covered. Rest of the body will be exposed to phototherapy. Fiber optic blankets can be placed directly under the infant. That is another method of giving phototherapy, that is fiber optic blankets. And encourage exclusive breastfeeding and tolerate short interruptions for feeds. So, exclusive breastfeeding will be continued during phototherapy because breastfeeding is helpful for reducing indirect or bilirubinemia, and tolerate short interruptions so that ensure maximum time to be used for phototherapy. Now, there are some adverse effects of phototherapy. Phototherapy is very much effective and most important treatment of neonatal jaundice is phototherapy, but there are some adverse effects. Transient passage of loose stools, then hyperthermia, irritability, dehydration. So, because of this dehydration, again breastfeeding is very important. Bronze baby syndrome in infants with direct hyperbilirubinemia due to impaired excretion of photoproducts of bile pigment. Due to release of these photoproducts of bile pigment, there will be bronze baby syndrome, and late complications like damage to DNA, skin malignancy, PDA, opening of PDA, gonadal damage and retinal damage. That is why genitalia and eyes are covered. Now, if the bilirubin level is very high, then phototherapy is not that much effective. In those cases, exchange transfusion will be done. Now, exchange transfusion, it is the most effective method of rapid removal of bilirubin. Phototherapy is most common and non-invasive method, but when bilirubin level is very high, we have to remove bilirubin very rapidly, and that is why we need exchange transfusion. It removes antibodies and sensitized RBCs and replaced with donor RBC. For normal serum bilirubin cutoff for exchange transfusion roughly in 25 milligram per deciliter, but there are graphs. We plot the level of serum bilirubin in those graphs and decide whether exchange transfusion to be done or not. Now, bilirubin albumin ratio to be done before exchange transfusion, because if there is albumin level low albumin level, that is neurotoxic risk factor, and if bilirubin is not bound to albumin, then there will be chances of more Kernicterus and chances of bilirubin passing through the blood-brain barrier will be more. Now, how to perform exchange transfusion? Via umbilical venous catheter through push-pull technique. The name of technique is push-pull technique, where the patient's blood is removed and replaced with donor blood. What is the ideal blood? Ideal donor blood, that is fresh type O irradiated PRBC that will be suspended in AB plasma and cross-matched against maternal plasma and cells. So, when we are doing blood requisition for exchange transfusion, mother's blood sample also we have to send along with baby's blood. Plain baby's blood is not sufficient. We have to send both baby's and mother's blood before for cross matching. And how much blood to be exchanged? That is twice the infant's estimated blood volume, that is 80 to 90 milliliter per kg, and 2 times will be 160 to 180 ml per kg. And intensive phototherapy to be resumed after exchange transfusion. Before exchange transfusion, intensive phototherapy to be given. After exchange transfusion, also phototherapy to be continued. And TSB should be monitored at 2, 4, 6 hours and then every 12 hours or 12 to 24 hours. Now, there are some complications of exchange transfusion. Thrombocytopenia, coagulation abnormality, hypoglycemia, hypocalcemia, hyperkalemia and acid-base abnormality. So, after exchange transfusion, along with total serum bilirubin, we have to check the blood sugar level, calcium level of baby. So, these are the graph for exchange transfusion when there no neurotoxic risk factor is present. This is one graph and this is another same graph for exchange transfusion when there one or more hyperbilirubinemia neurotoxicity risk factors are present. So, 2 graphs for phototherapy and 2 graphs for exchange transfusion. There are some drugs, pharmacotherapy, phenobarbital. It has been shown to induce the maturation of microsomal enzymes, ligandin and the enzyme for conjugation. So, these will increase the hepatocyte uptake of bilirubin in hepatocytes and conjugation of bilirubin. So, there will be more excretion, more uptake will leads to more conjugation will leads to more excretion. It is prophylactic and administered prenatally 1 to 2 weeks prior to EDD, expected date of delivery, and or given to the neonate within 24 hours of birth. Main treatment is phototherapy and exchange transfusion, but these are drugs we may administer. Dose will be 10 milligram per kilogram IM or STAD or 5 milligram per kilogram per day for 3 days. There are some drugs blocks enterohepatic circulation. So, there will be less enterohepatic circulation and less unconjugated bilirubin. Agar, cholestyramine, zinc. Orotic acid promotes conjugation of bilirubin. More conjugation will lead to more excretion. And then albumin. Albumin administration before exchange transfusion does not result in reduction in bilirubin level, routinely not recommended, but measuring albumin level is important. So, there are several drugs like phototherapy for except phototherapy, agar, cholestyramine, zinc, phenobarbital and this orotic acid, but routinely not prescribed. Now, bilirubin toxicity or acute bilirubin encephalopathy. Unconjugated bilirubin that is not bound to albumin, that can easily cross blood-brain barrier and cause kernicterus or acute bilirubin encephalopathy. And the blood-brain barrier is disrupted by factors like metabolic acidosis, asphyxia, hypercapnia, meningitis. Okay, so blood-brain barrier is disrupted. So, there will be more chances of passing of bilirubin through the blood-brain barrier. These are aggravating factors. Now, bilirubin crosses the blood-brain barrier and deposited in the blood, deposited in the brain, can cause bilirubin induced neurologic dysfunction. What are the regions affected? Basal ganglia, cerebellum, hippocampus, brainstem nuclei and auditory nuclei. So, this is important. What are the regions of brain that is affected in acute bilirubin encephalopathy? Most common is basal ganglia. Other regions cerebellum, hippocampus, brainstem nuclei and auditory nuclei. Acute bilirubin encephalopathy, bilirubin induced neurological dysfunction Bind score, that is 1 to 3, that is mild, 4 to 6, that is moderate and more than 7, that is severe form of acute bilirubin encephalopathy. I am not going to the details of this Bind score. Now, Kernicterus is more severe and permanent form of acute bilirubin encephalopathy. Most infants who develop Kernicterus had signs of acute bilirubin encephalopathy in neonatal period, and more than 75% of infants die and 80% of affected survivors have bilateral chorioathetosis with involuntary muscle spasm. So, the severe Kernicterus or severe acute bilirubin encephalopathy leads to chorioathetoid cerebral palsy. There will be bilateral chorioathetosis with involuntary muscle spasm. What are the signs of Kernicterus? Chorioathetoid cerebral palsy with neuromotor impairments, then sensorineural hearing loss, limitation of upward gaze, dental enamel dysplasia, And Kernicterus spectrum disorder, this is a broad term, but you must remember these signs of Kernicterus. Now, conjugated hyperbilirubinemia. What are the causes of conjugated hyperbilirubinemia? Conjugated hyperbilirubinemia means there will be level of direct bilirubin more than 20% of total serum bilirubin. Causes: idiopathic neonatal hepatitis, infections, torch infection or sepsis, malformation, surgical causes, biliary atresia, bile duct stenosis, choledochal cyst, Alagille syndrome, congenital hepatic fibrosis, metabolic disorders, galactosemia, tyrosinemia, cystic fibrosis, TPN, total parenteral nutrition, and CHPS, congenital hypertrophic pyloric stenosis. So, these all are causes of conjugate or direct hyperbilirubinemia or neonatal cholestasis. Diagnosis: if there is echolic stools that suggest obstruction, then lab studies to evaluate the liver function is deranged or not. LFT will be done, liver function test. Then USG, abnormal USG for diagnosis of biliary atresia, choledochal cyst, vascular malformations, surgical causes. Then hepatobiliary scintigraphy to differentiate biliary atresia from other causes, mainly to differentiate from idiopathic neonatal hepatitis. Then percutaneous liver biopsy, the definitive procedure to evaluate causes of neonatal cholestasis. Now, how to manage a case of direct hyperbilirubinemia? Low fat, high protein diet will be given, supplemented with MCT oil, medium chain triglyceride, and 5 times RDA, recommended dietary allowance of vitamin A, D, E, K. Okay. These are fat soluble vitamins. All vitamins to be supplemented the 5 times the recommended dietary allowance. Then phenobarbital has some benefit, and exclusion of lactose and sucrose from diet in patients of galactosemia. Then in patients receiving TPN, total parenteral nutrition, minimum enteral feedings, minimal enteral nutrition will be given, that is 10 ml per kg per day to be initiated as soon as possible. Then Cossai's procedure for biliary atresia, but it has to be done before 2 months of age. And infants with end stage liver disease can be managed by liver transplantation. End stage liver disease, no treatment or management, only liver transplantation. Then the short topic, last topic, hemorrhagic disease of newborn. Hemorrhagic disease of newborn, bleeding disorder, mainly manifests the first week after delivery. There are several causes like vitamin K deficiency bleeding, there may be trauma, there may be clotting factor deficiency, but mostly vitamin K deficiency bleeding is our today's topic, and that we also call the hemorrhagic disease of newborn. The causes: newborns have very minimal vitamin K reserves in liver during delivery, and newborns are not able to synthesize vitamin K due to sterile gut. Now, what vitamin K does? That activates the clotting factor, that is vitamin K dependent clotting factors. What are they? 2, 7, 9, 10 by gamma carboxylation of glutamic acid residues of clotting factor. So, gamma carboxylation will not be there, So clotting factors will be inactivated. Okay, so there will be bleeding. 3 types of vitamin K deficient bleeding: early, classic or late. Early, if there is bleeding first 24 hours of birth, that is early HDN. If 1 to 7 days after birth, that is classic HDN, and 1 to 8 weeks after birth, that is late HDN. Causes of hemorrhagic disease of newborn in early: maternal medications, that is anticonvulsants, antibiotics, anti-tubercular drugs. In classic HDN, due to lack of prophylactic vitamin K and poor breastfeeding. And in late HDN, the causes are fat malabsorption, that is biliary atresia, alpha-1 antitrypsin deficiency, poor feeding, liver disorder or GI disorder. Now, site of bleeding. Site of bleeding in early HDN: cephal hematoma, umbilical stump bleeding and intracranial hemorrhage. In classic HDN, the site of bleeding will be gastrointestinal, mucocutaneous and post-circumcision blood bleeding or umbilical stump bleeding. Intracranial hemorrhage is rare in classic HDN. It is common in early or late HDN. In late HDN, site of bleeding: gastrointestinal, mucocutaneous or intracranial hemorrhage. Treatment: what will be the treatment? In early HDN, vitamin K is not that much effective, so FFP will be given. In classic, both parenteral vitamin K and FFP can be given. Vitamin K in IM, intramuscular or intravenous route. Normally, we give in intravenous route because there will be more chances of bleeding in intramuscular route. In late HDN, parenteral vitamin K, FFP and recombinant factor 7A. So, we have to differentiate the causes of HDN according to the early, classic, late and manage accordingly. And prophylactic vitamin K injection 1 milligram after birth is very much important to prevent HDN or hemorrhagic disease of newborn, mainly in classic HDN.